Very fortunate to have a good panel here today. If I could ask you all to introduce yourselves, that's probably the most efficient way.
Sure. I'll start off. I'll stand up so you guys can see me. I'm Bill Gillis. I'm formerly with the Mayo Clinic platform. We're building a AI-driven platform. We're bringing together consumers and producers. We're not doing AI development. We're bringing together AI developers with consumers of AI and building a distributed data network that would allow people to take advantage of de-identified data sets outside of the data they have available to themselves. Prior to that, I worked locally here in the Boston area. I ran the accountable care organization for the Beth Israel Lahey Health Performance Network and the Beth Israel Deaconess Care Network, where we used data to really drive performance in value-based care contracts.
Thank you.
Hi, I'm Santiago Romero-Brufau. I work for Mayo Clinic as well. My job is I lead the AI initiatives in the Department of ENT. Where basically my job is to build and implement AI tools to help the clinical practice. And then I also teach a couple courses in the School of Public Health here in Boston at Harvard.
Hi everyone, I'm Mary Jane Dykeman. I am a founder of a law firm called... That's me.
Yes, that's you.
Okay. Founder of a law firm called Inc. Law, and we also have a global consulting company in data. In consulting, not very, not a huge choice in terms of the name by any stretch. I am in an interim role right now as Vice President, Legal and Risk for the Center for Addiction and Mental Health, teaching hospital in Toronto, and Deputy Chair of Canadian Blood Services. So I've been working in health and data for quite a long time and could not be more excited. I've said a couple of times over the course of the conference that nobody here will be retiring anytime soon. There's some issues to resolve. So thanks everyone for coming out.
Thank you.
I'm Cortnie Abercrombie. I'm with AI Truth, which is a nonprofit for AI ethics, which I founded after having been at IBM and doing AI incubating of solutions. So what I mean is, I said that in reverse order, not enough caffeine this morning. I went around to all of the biggest clients and looked for solutions that we could replicate using AI and machine learning. And as part of that, in order to understand if something will scale and be operational at other places, you have to first understand how the operations work of the data science teams. So I'm kind of like an unofficial anthropologist of data scientists. I went around observing them in their natural habitats and writing down all the messed up things they do. And then I was like, someone's got to take one for the team here and go tell the world, what's really happening in these closed rooms with these 5 guys who are kind of determining everything from insurance liability claims to social media command centers to, what we're all doing in this world. I mean, the influence of data science is much further than these 4 or 5 people, homogenous usually, that are in a room together determining for all of us who are very not homogenous, what we're doing. And so I had to go found this AI ethics. So I did that a long time ago, and now here I am talking with you guys. So I love this topic. So I know the guys didn't get a word in edgewise when we were practicing for this. So I will try to let you guys have a word because you're brilliant, and Mary Jane goes without saying brilliant. So.
Thank you.
Yeah, no. I'm just asking questions here. Thank you so much. Yeah. So let's start off by talking about the inherent biases in healthcare data. How do you recognize them, and how do you train the models? What do you do about that? So if we could, and I'll ask the question to the whole group. Who would like to start?
I'll kick it off.
Great.
I think that there's really no way to solve and get rid of bias. That's just something we're going to all have to accept, that the data itself, there's just going to be biases there. I think that what we want to look at is how do you create an understanding of a model and how it works with data. So you understand the ingredients of that data, so you know what populations that data works well with, what populations it doesn't work well with. And having that information up front, I think, is the direction, is my opinion, other than trying to say, we're going to resolve all bias. And I said a little bit yesterday, if we don't, as an industry, come around to the thinking of coming up with a plan of how we're going to deal with the ethical implications of AI and the inherent differences in the data, the government will, and they'll come down with a regulatory direction that may be very, if not impossible, to implement, very difficult to implement, if not impossible. So I think it's on us to really try to drive that future. I also, I think that it's really important to understand as you're bringing healthcare data together, and healthcare data in general is just very messy from system to system, how that data is entered. The way I like to say it is, healthcare data, that while we have standards are ice cream, and ice cream has 100 different flavors. The ingredients are the same, but the flavors are different, and that's kind of healthcare data, from my perspective. So it's important to really understand how that's going to interoperate so that algorithms can work from one data set to the other in some standardized way that you can report back on.
I think one of the things that is important to understand when we're talking about biases in healthcare data, particularly with AI, is there's a very important difference between biases that happen in any machine learning model, you have your predictors and you have your outcome of interest that you're trying to predict. Biases can mess up your project much more if they happen on the outcome of interest than if they happen on the predictors. Biases on the predictors are not that dangerous as long as they remain fairly consistent, because the model can adjust to them. But if you have a bias in the outcome that you're trying to measure, for example, if you're trying to measure readmissions, and readmissions is something that is biased because some patients, even though the need is the same, they have different probabilities of being admitted because of socioeconomic status or any other thing that could affect our bias. That can really mess up not only our model, but when we try to look at, well, how is our model doing, we can find that we can't even see the bias that is there, right? So that's something that I think is a very important take-home point. Be very, very careful about the biases that might be inherent in the outcome of interest that you're using your model to predict.
Yeah, I'll jump in because I think, again, of the continuum of the data, and it's not a simple fix to say, oh, we should just do better at the outset, collect what we need, be transparent, get consent if we need to, or if we want to, which we may. But at the end of the day, in that continuum, even when we're training models, creating some diversity in those that are doing the training, and also considering, and I take your point about regulation. It might be super clunky, that's a legal term, or maybe it's a clinical term. And if we don't turn our minds to it, I think part of the question is, well, where do we go then? Because when we talk about ethical AI, which we'll spend a lot of time talking about, I don't know how many standards there are. I think I stopped at 84. So there's looking it in the eye, deciding what it is, and also understanding that with forthcoming regulation, the assessments that will need to be done, including on bias, are likely to be mandatory. And if not mandatory, how do we account for it? So from a technical point of view, is there anything that we can do on that front as well?
And the main thing is to consider more data than what you have. And often it feels like in healthcare, the conversations that I've been hearing from everybody, that you're siloed almost because, you're not sure what you can do with HIPAA, right? Between other organizations' information. But the problem is that you're just not going to be admitting, like to Santiago's point, you're not going to be admitting every single patient, because a lot of people will ignore their health until they literally fall down at the doorstep because they've got, day jobs that include cleaning, or they've got some kind of manual job or something where they just cannot afford to take a day off. And those are unfortunately the people who often need it the most, but that we don't see in the data because they didn't come in for that follow-up, or they didn't do whatever it was. And I know I'm preaching to the choir because I see a lot of heads, going, So, your best bet is to try and figure out how I can account for those people, even though they may not be present in this data right now. And I heard a few good ideas throughout this conference, especially with the SDOH. Did I say that right? I'm trying to pick up healthcare terminology. But I mean, so there's lots of good ideas out there. You just have to investigate it and add to your data.
Wonderful. Thank you all. At the organizational level, have you guys seen, this is for Cortnie, Mary Jane, and Santiago, have you guys seen resistance to getting ethical AI projects off the ground, and how do you overcome that? How do you address that?
Well, first of all, ethical AI project, that's not a thing, but like it's just an AI thing, an AI initiative usually that it spans multi-year, so I hate to even call it a project usually, because most people, unless you're doing a research project that has a beginning and an end, you're usually continually, improving on something. But so the real question is when you have a first look at an initiative, and how is it coming to you? Are you an active person that gets to decide if this is the right solution to the problem? Because let's just face it, you don't always need machine learning capabilities or AI of any kind. But sometimes you do, and sometimes it's really important that you do. Sometimes you just need a straight up model, and that's not the same. But you first need to evaluate, well, what is the problem? And then when you start to look at, well, what's the most humane way? So I put out on LinkedIn today a list of 12 things that's kind of like a checklist for you as you go through and try to decide, is this going to be ethical? The problem comes in that we have trained our stakeholders, and stakeholders being, in this case, let me clarify, the executive funders. So we all have these people in our companies that are high up, they don't understand much about the technology, but they have money. Right? And they're going to give you the project and the resources. And the problem is they don't understand what it takes to get it done. You may understand that, hey, I can't interrogate this data for bias or anything else within 4 to 6 weeks and really be able to do something about it in that amount of time to develop an MVP. But we have trained them that we will develop and send out something so quickly within like 6, maybe 8 weeks, and they'll have something to see. But then normally you don't get to come back from that MVP, whatever it is that you created. You don't get to walk it back. They usually go, that's brilliant. Now just keep going. And you're like, but I need to do this the right way now. Like I begged, borrowed, stole, violated all kinds of data policies at other companies too. And I got this open source data and who knows where that's from. And I did all these things I had to do just to get the project, launched. And now this person who has the money is telling me I can't go backwards and do it the right way. I have to stick with what I have. And unfortunately, you have now a biased ground truth of what's going to now form the rest of your, because you start with that base and it just grows and it's lies. It lies.
So I'm going to think back to just pre-pandemic on the stage in Barcelona with a group of global CIOs on AI governance. And but one of them came over and said, and I think it was the beverage industry, so not an industry I know well. He just said, after we finished, I'm afraid to do anything, and I'm afraid to do nothing. And so I just highlight it because I'm pretty certain that if you were in that room, nobody is going to say out loud, I don't believe in ethics. But that's not what we ask. So when you bring that group together, I heard a lot yesterday about the use cases and the ROI. Sometimes we hear a little nervousness around impending regulation. What will it mean? Could we be at risk? Could we be on the hook if we don't get it right? And so it's less about a pushback on ethical AI, but recognizing we do need to build in those components as well. And they will absolutely ask, what's in it for us? What are we missing if we don't do it and our competitor is doing it, for sure. But I think we're going to talk about the culture as well.
Right. Right.
Yeah, I was going to bring up the culture a little bit because I think it's a key aspect of all of this, right? Like at the end of the day, AI is just a tool that is used. Yes, it has some specific problems, like it can obscure some biases in ways that other technologies cannot. But for the most part, it's just a tool that can get used and wielded whichever direction the company or the department or whoever's using it is going. So I think the organizational kind of characteristics that lead to ethical AI are not that different from the organizational characteristics that lead to ethical practice or business practice. It's often, I think, related to what are the values of the company? Are those values really defended, and so on? But also, it has a lot to do with the ability of any person in the team to raise a red flag and say, "Hey, have we thought about this potential unintended consequence, or maybe conflict of interest between our customers, our patients, and our own interest?" And having the ability of anyone in the team, whether it be the data scientist, the clinician leader, the business person, the administrator, to at least start a conversation and have that be a conversation that happens, and to have people think about it, I think is really important, right? Because oftentimes AI requires people from many different disciplines and many different perspectives that are looking at the problem. Sometimes some of them are going to identify a potential issue better than others, right? So it is important to have that, psychological safety for anyone to raise what a potential issue might be, and to be able to address it without this sense of defensiveness or this sense of like, oh, are you saying that we're doing something wrong, right? Like it's something that needs to be discussed. So I think those are kind of cultural or company culture characteristics that I think lead to better, more ethical.
So
AI
is it fair to say ethical governance needs to be in place to administer and understand and look at what's happening with ethics?
Mm-hmm. Yeah,
Well,
something
throughout, because I'll echo that. Set the ground rules. It's terrible when it comes to that point, but people need to be free to say it, and then there's a decision potentially to be made, or maybe there's something to remediate. But if it goes very wrong, and we're not going to put it out there, I would make that the case study of how we protected individuals. We had a conversation, Carolyn and I, last night about, the 11th hour, something went really wrong, not in her company, nor in mine, but just the fact that if it's going to come out or it's going to come to harm, you need to set those ground rules up front and have those touch points along the way, and the freedom to say something's going terribly wrong.
Yeah. So along that line, next question for Bill, how do you set up front, how do you set the model to understand how you're getting the algorithms developed and that you've got the right one?
Yeah, and I think a lot of it almost ties right back to that last conversation, which is setting that ground, the foundation, what is the ground truth of where you're starting, and having governance in place early on, and understanding that governance is going to shift as you learn more, but having all of those checks and balances across the way. And I think where people run into challenges, I don't think, for the most part, nobody wants to operate, without ethics in this space. However, things operate at the speed of business. Money is spent on things, and when you get to the 11th hour and say millions of dollars have been spent, and somebody says, "Wait a minute, we have a consent issue here. Stop, we're not going to go forward." There will definitely be stakeholders that will say, "No, we're going forward. We've spent too much money." And how do you account for that? And I think that having those checks and balances as part of what your model is going to be, if you're going to get into this space in healthcare, governance is key. And getting the stakeholders to all believe in what that governance, and not just agree to it, but they've got to believe in it. That we may have to pull the plug on something because we've discovered whatever it might be. That there's so many threads to pull with this, as far as a patient's data being used for something, and what the consent that they're giving for payment, treatment, and operations versus research versus development of an algorithm that can detect early disease states for other patients, and that gets commercialized. Well, what value goes back to the patient for that? I mean, these are all things that I think have to be thought about. We're never going to get, say these are the 50 things. It's going to be a growing list, and will it be ever growing? But I think having that safety net, making sure that the governance is there from the beginning, is really the key component.
Wonderful. Yeah. So for Bill and Santiago, where does the data scientist responsibility end and the physician's responsibility begin? Talk us through a little bit of thoughts on that.
Do you want to?
Yeah,
As a physician and data scientist, this is the
all on
whole
you.
reason we brought him.
Right. So there's one question. So it's a very difficult question to answer, right? So on the legal side, my understanding is that the final decision is always from the physician, so the responsibility is always from the physician. But this is something that, lawyers said this hasn't been tested, right? We haven't had a big case in court where this has had to be decided. So I think until that happens, it's going to be very hard to know exactly how much responsibility does the person or the organization or whoever built the AI system that is recommending things to the physician to say, well, yes, the physician was making the decision, but it was being misled by this algorithm that you built, so you're liable for, whatever. It's a very difficult thing, and I don't think we truly know the answer yet, at least on the legal responsibility side. I think that makes it even more important than that whenever you're building an AI project, that the person building it, that the data scientist that is building it, needs to take into account how the information that they're providing the final decision maker, which is typically a physician or a clinician more generally, how they're going to be interpreting that information. And are you communicating accurately what the accuracy is, what your confidence is in those predictions or in those nudges that you're giving? So that can be taken into account with the appropriate size of salt. What was the expression? Grain of salt. Yes, the appropriate size of a grain of salt, right?
Yeah, and I think that it's a tough balance, right? The data scientists are thinking from things from an engineering science of the data structure standpoint. Clinicians are always thinking about the patient. And I think when you think about things like using AI for clinical decision support, there is a balance of responsibility there where the tool is providing information to a clinician. The clinician needs to have some level of confidence, and I think that's kind of where we are right now as an industry, is how do we get the confidence in the clinical folks to be able to do clinical decision support and take it out of their hands. But if you kind of think back to 10, 15 years ago doing med reconciliation and drug interaction off an EMR, there was a lot of concern like, well, wait a minute, I'm putting all my faith in this computer to tell me the medications and whether there's any interaction going on. But that all happened. There was confidence in the products. There was some learning that went on. I think we're going to be in that same space of getting the confidence with the physicians. But at the end of the day, the physician is the physician and wants, you want to be able to look at the data and say, well, gee, that doesn't really make sense. I want to go back and check that, It's kind of like, relying on a GPS and it drives you off a cliff. And you say, but the GPS told me to go left. You've got to really take in the information and really, question the tool itself. The tool in and of itself is just a tool. You've got to decide how to wield it.
Yeah, I'd like to comment as well. I agree. I think there will be some litigation. We all hope that we're not the test case as it happens. I also wonder whether there might be cases where a clinician had the availability of the technology and chose to override it, and fair enough, because ultimately it is that physician. I think there's going to be a lot of augmented AI, as opposed to the full-on, set it, forget it, not my responsibility. The clinical judgment still has to be there, but there's probably a narrative that we can do a better job with clinicians to really set out, how did we get there? Because a lot of the groups I work with will say, oh, we got it to 94%, whereas the radiologist was at 90%. Well, not so far off. But again, that clinical judgment ultimately, and this is the worry. Often if I'm in a room with clinicians, they come up afterwards and say, well, wait, am I going to lose my house?
Right.
So I think there's a bit of work to do on what is the technology, what is it going to do for you, and where does it leave off, recognizing it will get tested without a doubt. We've seen it in other sectors, like in the investment sector, for example.
Yeah, but the hardest part is that you got like 17,000 new ways to look at your field. Like there's always new medical case studies coming out, new clinical trial information. They're always releasing, like I think, what did I read? Like doctors, if they were really going to do the job like AI would do the job, for example, you would, of reading, not just the reading portion. There's so much more. But if you were going to try to just keep up on the newest, latest trend or the latest thing that is helping patients and all these little caveats to all the nuances of health that we all have, you would have to read something like 17,000 different papers a day. And that's like impossible for a doctor. So the upside is the best way to do it is the augmented approach, where you as a doctor will be using these things as tools to help you understand the new things that are out there that maybe you didn't have in your consideration set before. And that's, instead of thinking of it as like a possible liability, you think of it as, okay, this just opened my eyes to something new that I hadn't considered before. And as a way to kind of major on certain key issues having to do with all of our specialty problems. So.
Thank you. Next question is for Mary Jane. How do you think healthcare and pharma companies, this is a sticky one, can best embody the moral responsibility associated with AI?
Well, and again, that's a tall order. I don't think anyone in this room or in pharma or health is going to say, oh, we're going to dodge the moral aspect. Quite often, and I often draw on health research because I've worked in that for a long time, pre-ML AI. I ultimately think that we're going to have laws. Laws are not the full subset by any stretch. That's almost a baseline if and when they arrive. And if we don't adopt certain standards along the way, as you've said, it's going to happen for us. So we've got to sort of get in there. So law doesn't cover all of the ethical aspects, but I think there's simply a roll up your sleeves, get the work done, adopt those standards. They exist in a variety of places, and create that AI governance and just move it forward. Because again, back to my guy in Barcelona, the not sure what to do, a little bit of fear of missing out is probably not going to be enough.
So you're saying that those issues are probably already created and just it's a matter of incorporating it?
Well, there are many standards.
The standards,
I think, the OECD, IEEE, we've got emerging regulation in the US, different states have adopted AI. Constraints, bias reviews in employment settings and everything else. So we can expect all of that. That doesn't make it moral or ethical. Again, it may be clunky, but if there are 84 ethical AI frameworks, just pick one, create those principles, and often, again, in health research, people will say, just tell me what I need to do. Like, make it simple. Don't make it opaque. Don't make it 6,000 words. Just give me a framework, and we will make our way through, but let's go. So I think it's happening. It's not to say that everyone is standing at the fringe with it. There's some really sophisticated groups doing great work, but it has to move. Just thinking that the legal doesn't cover the full spectrum of ethical and the things that we're talking about here, the pauses, the transparency, and the ability to sort of iterate and make sure that we don't just drive full speed ahead without those checks and balances.
I have to say one thing too, because we always talk about there's like a gazillion principles, but really there's only one. And it's the same one that guides you through your life every day probably, and it's do unto others as you'd have them do unto you, right? I mean, basically that's really all you have to remember. You just can't check your one self at the door when you come through to your virtual work or your regular workplace. You have to keep the same morals. If you wouldn't take someone's $20 that they just dropped out of their pocket and you saw them, you'd go chase them down and give it back. You also can't let your AI and your machine learning capabilities do the same. And what I mean by that is you have to be looking. you have to look at your model the same way that you look at your life and determine, am I leaving someone out? Did I inadvertently exclude somebody? Is there something here that okay, if I think about my grandma, would she be able to afford care if I set it up like this to only approve certain claims for this and this? How can I think about this from the standpoint of a person, not I'm using a machine learning capability that I'm just gonna squeeze out whatever I can. I'm gonna look at it from my own standpoint. And I know this is gonna sound strange, but we confuse fiduciary responsibility a lot of times with actual what we as people value, and it actually puts us in contention with our jobs and stresses us out, actually. If you really think about the things that you've ever been really truly upset about in your work life, it's usually things that you're being asked to do that disagree with what you as a person would do. And so you have to figure out, how do I bring who I am as a person and what I value into what I'm actually doing? Am I being inclusive? I wouldn't exclude anybody, so I wouldn't exclude them in my algorithm. I will try to come up with a way to think through that, you know? Mm-hmm. So it's really just one principle, the golden rule.
I think it's true, but I just want to add, sometimes people have that different risk appetite. Or they might say, you know, I scroll down and I click I agree on any app. I don't read it. I don't really care. I want the benefit. So there's probably a refresh and a reminder on the moral compass, or whatever we call it, because that you know, sounds very high level and judgy. But
and whose compass do you use?
Well, exactly.
That's always the
Again, so in the room, what are the checkpoints where, as that group, you can do that and not place it on one person, because one of us could have a great risk appetite or say, but those are not things. But I think there's a human rights lens, of course. Yeah, it's
because
that pause.
you're rushing usually. As a data scientist, you're just rushing. You're just rushing.
And
You're not thinking.
about it at some point.
But that's the governance, right? Having
Exactly.
that groundwork governance almost before you start doing it, because you try to put governance in after the fact, and it's easy
not a
to
retrofit.
bend the rules a little bit to fit the outcome. But if you describing what Cortnie's saying, if someone has that, boy, I don't think I'm doing the right thing, the mechanism needs to be there that they can freely, without retribution, bring that forward. And that should be the culture, right? It comes down to how the culture of an organization would be. Now, to the other side, it's, should the individual be the one making the determination? No, there should be a cultural structure of governance and how we plan to do things, but there's always going to be someone along the way that feels, I don't know, they should feel safe to come forward. Maybe it's a valid concern, maybe it turns out it's not, but those mechanisms need to be in place, because otherwise it will become a fiduciary goal, not necessarily an ethical goal.
Right. Well, thank you all. Last question, what are the greatest potential and possibilities for patient safety and treatment? So let's kick it up a notch. Where could we be headed with this? Where's when these models are generating, what do you see as the best and brightest opportunity here? And that's a question for everyone.
So this is my whole speech this afternoon. If you're still around at around 3, the 3 people that are left, I will tell you all my 3 o'clock on a Friday. I will tell you all my views on how this all can converge together, but we're not going to get a single bit of that to work in the future if we can't come together and figure out how to get more trust built into these technologies, because right now we haven't earned it. Honestly, I think if let me just tell you, I think that personalized care, which is what, I don't know if you guys are here, that we were talking yesterday at the table about all the ways that we could be using sensors and all the wearables and everything in our environment around us, and these phones where all of these technologies converge. And think about how many things you can control with Alexa skills nowadays, for crying out loud. I mean, the things we can control with phones in our lives is amazing. And when you think about how many specialists we have that we ultimately will see as we get older, we'll add more and more of them. Like, you know, they're all going to prescribe. Like, you may have someone that's for your heart, and then you'll go see someone for your GI, you'll go see someone for this. And they're going to give you 2 medications, 1 medication, and then they'll give you a set of instructions and another set of instructions and a portal and a different portal and another portal to check all your vitals and everything else that you're supposed to be checking. But what if we could just pull all that stuff together? That would both terrify you right now because we're not there yet on the trust factor, but it would also be like, wow, what if I could do everything almost as easily as I talk to Alexa, and I could just talk to my environment around me and remember to take those pills, or have 2 pill bottles that can quickly determine an interaction so that you're not having to look it up online. You know, it's going to tell you, hey, you just set a pill bottle next to my pill bottle, and those 2 don't go together. You need to, you know, do something. Send off an alarm. I mean, I see there's so many ways for us to bring everything together for ourselves so that we can see our own health. If you think about today, the way that a patient sees health, think of a patient when they walk in, they can't see anything to do with their health. They have to go to 50 different portals to see their health. They have to go to a nutrition app, and then they look at, you know, some of the heart rate stuff that's separate. It's all separate, and it doesn't make sense as a whole person together. And I think that we can do better than that. And I'm excited for that. But first, I think we have to earn a whole lot of trust before we get there.
Yeah, little bit of work to be done. I would say I have a teaching hospital client that, as part of their priority, has said anything that is improving the patient outcome goes up the list, because they vet their use cases really carefully. If it's a system efficiency, and there's lots of opportunity in healthcare to do some of that, that goes to a certain place below. If it does both, even better, and top of list. And then they sit and sort what they want to prioritize. And of course, as I said, we heard a lot about return on investment and everything else. And then I think we have to link in the trust, the public narrative, for all the right reasons, but then also thinking about the business opportunity. I think we do a disservice in not engaging the public, because what do they see? They see what's on the front page of a paper, they see what's doom scrolling on social media. We are not telling a good story, a good, true story about data and the opportunities that are there, that the care that we are taking, the challenges that we face, what is their part in it. And we're replicating some of that, because again, back in the early health research days, we excluded certain groups, we passed over, we created data with bias. We can do better, but my gosh, if I were that person, the person you're describing, and we all are at some level, whether it's us, for a parent, for a child, whatever it is, navigating the health system, what is the opportunity of AI? And let's get this in place, roll up our sleeves, do it in an ethical way, but do it and tell that true story.
Thank you.
I think in terms of the benefits that AI can bring in healthcare, and this is, I want to be clear, I'm not speaking on behalf of any of the organizations that I work with, just...
That's the legal caveat.
Right, exactly.
The disclaimer, I'll put the sign up.
What I'm going to say is, can be quite unpopular or ruffle some feathers. I do think AI has the potential to transform fundamentally the role of the clinician, right? Like, I think currently clinicians see themselves as people essentially crunching the numbers in their head, like adjusting the risk for this patient, and there are these risk factors, and then what is the most likely diagnosis, doing a lot of these like essentially computational work in their head. I think that is going to be taken over by AI for the most part, right? And then the clinician is going to be dealing mostly with the human aspect of the interaction with the patient, of understanding the patient's values, of understanding how those numbers that are crunched by an algorithm are going to fit into this specific human life. Because, and you mentioned that earlier, right? Like the possibilities and the computational ability of an AI is just so much bigger than the ones that humans have. we're seeing a lot of cases where the AI is outperforming humans at very specific tasks. Just looking at the evidence, right? Just being able to read the evidence. Well, 17 papers a day is impossible for a human to go through. It's nothing for an AI, right? Like you can do it in 5 minutes if you have the right computational thing. And the good thing is you only need to do it once, and then you can extract that information, and then you can spread it instantly to and update any of the algorithms that you have. That is just not feasible to the possibilities of scale that provides is just impossible to compete by purely a human system, right? If you think how long it takes to train a doctor and the cost associated with it, AI offers so many more possibilities in that I think is going to essentially transform the way medicine is practiced in ways that I think can be really good, right? Like in a lot of the world, there's a shortage of people trained clinically because it takes such a long time to train, right? We've amassed all this knowledge throughout the centuries, years, decades, about how best to treat and identify the problems that people can have in their health. It takes a long time to train people in it. If you can have an AI, you can make it available on a smartphone. Now you just need someone to translate what the patient is saying to what the algorithm knows, and then you can have, we're not there yet, right? We're very far from that, but if we extrapolate the possibilities of the technology into the future, I don't know if 10 years, 20 years, 50 years, I think that is where we can go, and that is, I think, a very exciting thing.
Thank you.
Yeah, and I think it's, it kind of comes back to that old, analogy, crawl, walk, run. And I think what, in some ways, we're talking about AI as clinical decision support that's going from crawl to sprint. And I think there's a journey in there to get to that place where you can start to use these tools for clinical decision support. In some cases, like imaging or, ECG signal interpretation, it's pretty straightforward, and the science has proved out that there's not a lot of challenges in being able to use that for clinical decision support to some degree. But I think that what we have to do, and where I see opportunity is, well, do we need to go right to clinical decision support? There is opportunity here to use AI for population health management, which becomes a win-win all the way around, right? Understanding populations of people, and say, an example would be, you've got an AI algorithm that can detect low ejection fraction. So you take that algorithm, you run it against ECG signals that you've got in your ACO population. People that are not diagnosed with a condition, run those signals through, it determines, gee, there's 200 people here that have not been diagnosed with this condition. Bring them in for a visit, and then have the cardiologist dive deeper into that condition, see if they do have a problem or not. There, it's not clinical decision support, it's supporting the physician making a decision himself. And it helps the patient, it gets people in with conditions that they may not know they have, that weren't diagnosed in the past. So I think of it, the opportunity that walk stage is, let's not wait for the perfection on clinical decision support. Maybe there's ways to use some of these algorithms now to benefit patients that are out there with conditions for population health management, for getting back to the patient and giving them the ability to get some care that isn't really about clinical decision support. Because I think that there's some real opportunity there and a lot to be learned. So much could be learned around some of the earlier discussions around ethics and setting governance. By having those tools out there, you learn how are you retraining your algorithms based on, not a popular term, but the term I use is data exhaust that comes out of an insight generation. You don't want to get that information, that metadata that comes out of an insight generation to improve the model. And how are you going to build those mechanisms around doing that? That can be part of the walk. The run is clinical decision support, where the physician is not burdened as much with keeping all the calculations in their head and having to do all of that.
Wonderful. Thank you all so much. Do we have time for questions or no?
We could do one question.
It better be a good one.
It'll be a lottery.
Hi, thank you for your talk. One of the things we were talking about yesterday and came up in our discussions was the ethical considerations about the types of data that we have, because I think we had mentioned that a lot of the data that we do have are for people who are able to access healthcare. And so that ends up, leading to biased models in terms of, trying to predict risk and things like that. And so how have you experienced that yourself in the work that you've done, and how do you think we can reach those populations that may not necessarily be accessing healthcare? Or if we're not able to reach them, how do we generalize the models that we do have to be more applicable to patients who are not able to access healthcare to the same degree?
Yeah, it's a great question.
You were all looking at it.
I'll take the right. I'll take the hit. It's a very good point, right? And it's one of the elephants in the room when we're talking about all of this, right? That all the models that we're building are built on existing data. Existing data has the limitation of it's the data we have because it's the people that come. I do have to say this is a bit more of a problem in the US than in other countries where you have universal access to healthcare. I'm originally from Spain, for example, and over there, everyone has access to healthcare. It's part of your, what you have a right to as a citizen. So the data there, it's of course, there's some limitations in the data there, but at least that fundamental bias is not necessarily there, right? You have your coverage of the population is much broader. So I think there's going to take, and I think this is something that we're currently seeing a little bit of, but I think it needs to increase a lot more with data availability and that sort of thing, to take models that you develop on one set of data and then try to generalize them, try to see if they work just as well in another population. Using those populations that we can be more certain that they cover a broader proportion of the population is going to be very important. That of course doesn't solve most of the issue. Like for example, in Spain, the racial diversity is not very high, right? So you're still going to have some of those problems that are going to be a bit harder to solve. But as long as your model is not likely to be affected by those differences, I think that can be a good way forward.
I think we're also seeing the emergence of apps that are now for symptom tracking, which, I mean, I don't know if people have certain problems, now they're just turning to apps because they don't have time to go into the doctor, which honestly, however they get help, as long as they do in some way that's not misleading to their health, then, all the better. But maybe those will start generating enough data for all of us to understand and get at soon. That's all I can say on that.
I think part of it is validation of algorithms, what I like to call it. So understanding where the algorithm works, and not using it in populations where it's not going to give you a good result because of the data that it was built on. Now, that doesn't solve the underlying problem, right? The underlying problem is we don't have the data for a lot of populations in this country just because people don't have access. Or their only access is, urgent care or emergency room, and they don't have health insurance, so it's not getting tracked. So understanding, like, how do you validate an algorithm to come up with, I think I had mentioned it yesterday, this nutrition label for an algorithm to say, these are the ingredients, these are the populations that were used to develop it. This is where it works well, this is where it doesn't work well. And knowing that before you're using it and understanding that, I think also ties to the ethical and governance capabilities. I think we'll always be challenged to get the data for all the populations. I ran at Beth Israel Deaconess here in Boston at the ACO we were a Medicaid ACO, and we thought, all right, great, we'll just make sure we gather all the SCOH data through questionnaires in the physician's offices. Well, there were 38 questions. There's no way a physician can sit down and gather 30, and these are questions, where did you go, what was the last, the highest level of education, how long have, how often have you changed your residence, and how transient are you? They're not things you can just gather quickly. So it really kind of failed in some ways. We were trying to get the information to help our data, but to get it was a challenge in and of itself. I think that's always going to be there.